The knot that I'm going to teach you guys tonight is called the water knot. I thought it was appropriate because we're doing river medicine tonight with Randy. So the water knot is used to join two pieces of webbing together. So it can be useful if you're trying to make a loop out of a piece of webbing, or say if you had like a backpack strap or something break, you could join it together. So whenever we're doing a knot, some quick terminology would be the working end and the standing end. So the working end is the end that you're moving. The standing end is the end that stays the same. So in order to do the water knot, first you're going to take the working end and cross it over the standing end, and then pass the working end up through the sloop, like so. And that creates an overhand knot. So in order to join these two together, essentially what you do is you take the other piece of webbing and you follow this other piece of webbing. So starting from what was the working end, you follow it through. And again, trying to keep these, like both pieces of webbing, flat against each other with no twists. And you just follow it all the way back through. And you should end up with something that looks like this. And so then if you pull each end individually, that is a completed water knot. And these two pieces of webbing are now joined together. It's quite a strong knot. You can also tie it with cord. It's not quite as strong. One of the key points to remember with this knot is if it's going to be loaded and then unloaded and then loaded again and unloaded, sometimes the ends can slip a little bit. So it's important to keep these ends, or we like to call them tails, at least 3 inches long. So I'll go through that one more time real quick. So you get your first piece of webbing, and take the working end, cross it over the standing end, up and under and through. That creates a loose overhand knot. Take your other piece of webbing, start from the underside of the working end, pass it through, and then follow that other piece of webbing around, keeping both pieces of webbing flat against each other. And once you've passed it all the way through, just give the opposite ends a tug to tighten it up. That's called a water knot. Now, it's kind of hard to have 50 people ask questions and get individual input on how to tie it. So I suggest going and looking up a video and practicing it on your own time. And hopefully the next time you break a backpack strap or something like that, you're able to just join it back together. That's the water knot.
Okay, so tonight our speaker is Randy Howell. He's an emergency medicine PA at the Carilion Clinic in Roanoke, Virginia, and he's also the Advanced Practice Clinician and Emergency Medicine Fellowship Director at Carilion Clinic. He's an assistant professor at Jefferson College of Health Sciences in the PA program. Randy has been an active wilderness medicine member for many years. He serves on the board of directors for the Appalachian Center for Wilderness Medicine. And if you don't pronounce it Appalachian, Randy's happy to give you a tutorial. He also works at Snowshoe as a ski patroller during winters and ACE Whitewater as a river guide during the summer and fall seasons. When not working or teaching, Randy can be found on the river. So with that, I'll turn it over to you, Randy.
All right, I'm going to share my screen here with all my awesome new technological skills. So thank you very much, Gina, for the introduction. I do want to make one quick adjustment there. Jefferson College of Health Sciences is now has now merged with Radford University, so we're now Radford University Carilion. So that's the adjustment there. Yeah, so tonight I'm going to talk with you guys about river emergencies or river medicine, and so I'm going to talk kind of about there's not going to be a whole lot of probably new information from a wilderness medicine standpoint. It's more just talking about some of the concepts that we use when we're in the river environment. And some of these things I will move through somewhat superficially, simply because there's going to be so many other talks on these. Like, for instance, we're going to talk a little bit about hypothermia, but there's going to be a whole other talk on that. So I'll talk about it a little bit. But what I'm going to try to do is take a couple of the concepts that we deal with in wilderness medicine and talk about specifically how that applies to the river environment. So this is entitled "Rig to Flip and Dress to Swim." That's kind of a saying that you'll hear in the river community. It's kind of like planning for the best and hoping for the best and planning for the worst. You should always rig your boat as if you may flip it, and you should also dress as though you may swim. So again, as Gina mentioned, I've been active in wilderness medicine for a number of years. I'm actually an alumni member of NSP right now. Right now, my kiddos are young enough that I'm skiing with them. So I'm taking a year or two off of patrolling Snowshoe to ski with them. So at any rate, I've also done some OEC training for the National Ski Patrol, AWS instructor. In fact, some of the things that we're going to talk about with drowning and hypothermia actually comes from the AWS curriculum. So I think probably kind of starting off, I want to kind of emphasize at the beginning, emphasize at the end. This is kind of like, a big introduction to these things. I really encourage everyone here, and again, based on the fact that you are here for this talk means that you're very interested in wilderness medicine. I cannot recommend more highly actually getting some of the formal training courses that are out there. So there's a number of them: AWS, WALS, WMP, all these things. There's actually, it's encouraging over the last probably 8 or 9 years, there's been more and more, much more availability for wilderness medicine training. And if you're interested more in like kind of the river rescue element, I definitely recommend looking at some of the formal swiftwater rescue courses there, so you can get really in depth in some of these things. So again, our talk tonight is going to kind of touch on some things that I feel are important for river medicine. And like I said, I'll be watching the chat box here if you guys got any questions as I go. Really quick, I just wanted to clarify about how much time do I have. I just want to make sure that I'm staying on time.
You have an hour.
Okay, great, good. Okay, so I just want to make sure that I don't go over. As you may or may not have noticed, I get a little verbose sometimes. I like talking. So at any rate, I'll make sure that I'll stay within the hour there. So at any rate, and I'm going to try to make sure we've got some time at the end for any questions that you have. So let's get started. So objectives, we're going to talk about resuscitation and stabilization techniques in the river environment. We're going to outline the management of trauma, drowning, hypothermia in the river environment. And we're going to discuss injury prevention strategies as well. So the river environment, let's talk about that a little bit. It's awesome. It's fantastic. It's one of my favorite ways to be outside. If none of you guys, if any of you have not participated in a multi-day river trip, I cannot more highly recommend it. It doesn't have to be a big whitewater trip. Just being out on the river for a number of days is fantastic, and even just getting out there for a day. So the reality is that the experience of being on a river is something that's incredibly special to me. It's been a big part of my life and something that I hope I can do for as long as I can. Another thing that you'll notice is the community of river folk is a fantastic group of people. And one of the reasons I wanted to bring that up, it's almost more than just meeting nice people and making friends with them. I think that one of the things that's kind of unique, you see this with any kind of outdoor activity. One of the things I think I've noticed even more so in the river community is that everyone's there to help each other out to a great extent. So, I've certainly been on the receiving end of rescues from a perfect stranger, and I've certainly performed rescues and helped out folks that I didn't know. So it's one of those things that once you kind of push off from the bank and you're out there with these folks, even if they're not in your group, everyone out there is really a really fantastic community. And to be frank, many times most of the successful rescues that occur on the river are often by people that witness it, either people in your group or people that happen to be on the river there. So as you can imagine, often trying to get just the time constraints of getting professional rescuers there can be a significant factor, particularly if someone is in a drowning situation. So often the folks that are affecting these rescues are people that are on the river that you may or not even know. So again, great folks out there. You also run into varying levels of resources and expertise. So depending on or the group of people that you paddle with, or the river that you're on. Some rivers somewhat self-select for different skill levels based on their difficulty, but you'll encounter lots of different people with many different skill sets, and also depending on the type of trip that you're on. If you're doing a kind of a great roadside park and play, or a short trip down to a whitewater run near your hometown, you're going to have different kind of equipment and resources there than if you're on a 2 or 3 week trip down the Grand Canyon on the Colorado. So again, it's an interesting dynamic there as well, because you'll often have to improvise in different ways with different levels of resources. Also, the river environment's dynamic. It doesn't stop. And again, I think in particular, if there is an incident on the river, it's not like there's not a pause button. Often you're out there dealing with moving water, which is incredibly powerful. Often you're dealing with other environmental factors there too. So it's a very dynamic environment, and that comes it comes into play both in the active rescue of folks that are in trouble, and also evacuation and treatment modalities that we may employ there. And often, particularly permitted rivers, or rivers that you do multi-day trips on, often they're quite remote. So you may be the best health care that is available for your team there. So that's something that's really important when you're thinking about, again, planning for the trip. And again, like a big river trip doesn't start on the day that you put off on the river. It often starts weeks and sometimes months before, with the planning and preparation that you have. So again, it's most long, big multi-day trips are in remote locations. That's not to say that you can't, but there's not plenty of water close to cities and towns, but a lot of times on these bigger trips, you're often pretty far out there. And then that kind of leads to evacuation considerations. If you're on a river, particularly if it's a big whitewater river, there's a better than ever chance you might be down in a steep canyon somewhere. So getting people out can be kind of challenging. It also there may be a situation where sometimes the safest evacuation is downstream. So that's one of the other things that kind of plays a role in kind of the way that we embrace our evacuation considerations there. So a couple pictures here down at the bottom, just to keep things light and fun. Over here, I guess on your left, as you face the radio dial here, that's a typical kind of like little raft camp setup. I believe it's on the James River in Virginia. Here on your right, that's the put-in for the Middle Fork of the Salmon in Idaho. As you can see, it's a busy day. Lots of people are excited to get out there. So let's talk a little bit about the big three kind of things I want to talk about a little bit from, I guess, a river environment perspective. I want to talk about trauma. I want to talk about drowning. I want to talk about hypothermia. And again, these are all, like, you could have a complete, hour or two lecture or an afternoon workshop on all of these things. But I'm going to kind of try to take these three things that I feel like, if you're going to be out on whitewater, particularly big whitewater, remote whitewater, these are really three things that I think are imperative that we were thinking about as we, again, are participating in these activities and rendering aid if necessary. So wild wilderness medicine, again, that's one of those big questions that we ask. It's again, in this audience here, we all got into wilderness medicine for lots of different reasons. For a lot of us, this is why. Okay, this is what happens when you take your kayak to a class 4 rapid upside down. I'm not sure what got me. Might have been a paddle, might have been a fish, might have been a rock. I don't know. I was wearing a helmet though. I want to make that clear. But again, most of us get into wilderness medicine is because they want to take care. They want to make sure that we can take care of ourselves and those around us when we're playing outside. So another thing that I think, just in general terms, when you think about wilderness medicine, this is something that I try to incorporate whenever I talk to folks about this, is that level of care should not necessarily define quality of care. So for instance, if you've got a 23-year-old male that's got a bilateral femur fractures and you're in the trauma room at the level 1 trauma center, you've got all the resources there. You've got trauma surgeons and highly skilled emergency medicine professionals. You've got radiology. You've got all the bells and whistles. So you've got a very high level of care, and you're able to deliver great care that way. Now think about that same 23-year-old male that has bilateral femur fractures, and maybe you're a couple days, maybe you're like, I don't know, 3 days into a week-long trip, and maybe the closest evacuation point might be a day away. Still, even in those low resource environments, even without the same level of medications or diagnostic modalities, even within, I guess, those limitations. And we do have to set our expectations appropriately, but still, we can still deliver excellent, superb patient care, even in low resource environments. In fact, some of the best medicine I've ever practiced has been on the side of a mountain. So again, it's one of those things that I kind of like to kind of insert there for us to be thinking about, whereas even though we don't have those resources, we can still deliver excellent care within the restrictions that we encounter. So let's talk a little bit about trauma on the river. Okay, so again, if you Google I need a picture of some folks not wearing life jackets on the river. This is kind of what pops up. So we all know that smoking's bad for you. Okay, we'll have the scope of this conversation, but the thing is that can anyone take a look at that picture there and see like anything jump out at you that might not be maybe the safest way to go down the river? Let's see here. Gotcha. So yeah, so again, I see a couple responses. So really, the first thing we kind of jump out at, there's nobody's wearing any life jackets or PFD. So you'll hear people use life jacket and hear people use PFD, personal flotation device. Nobody's wearing those. Nobody's wearing helmets. I'm not sure why that fell in the back standing up. I mean, but at any rate, it seems like two of these guys have, superb mustaches. That might be part of their personal protection plan. But the reality is, and again, just to kind of keep things a little bit light, because some of this stuff can be kind of heavy subject matter. Right now we can look at this and say that there's probably some room for improvement here in their plan for personal protection. So again, another example. So a lot of times people think, when you think about river medicine, the first thing people think about is drowning. And of course, that's a big part of it. But a lot of times people really don't think that maybe as much. And I think that's important as well, because we can look at this. You can say, well, I'm not a trauma surgeon, but I believe there's a pretty significant mechanism of injury here. There could probably be some bad things happen. Again, these people, when they woke up this morning, they did not think this is the way that their day was going to go. So again, you see the folks up here in the front of the boat. You got one person falling out. Actually, the two people in the front might be even a little bit protected. But if you look at the back of the boat, that is just a mass of humanity banging into each other. It even seems like one guy's getting kicked right in the face. So at any rate, whenever you think about someone, again, if someone does have a big capsize or does have a big swim, you've got to be thinking about a traumatic process and not just drowning. So rocks hurt. Most of the time, if there's a rapid, there are rocks involved. You want to have a high index of suspicion for concomitant trauma. C-spine precautions when the mechanism of injury and presentation warrant. I know that we're looking at like immobilization a little bit differently now, but again, it's one of those things that if you suspect that there could be a C-spine injury, you want to kind of make sure that you are keeping that in mind as you're rescuing and evacuating the patient. And we're going to talk a little bit about some systemic assessment strategies as well here. So again, just to kind of reemphasize that, if you've got somebody that's taking a big swim through a big rock-filled rapid, when you are rescuing them, you've really got to keep trauma front in your mind and making sure that we are paying attention to that early and addressing that early. So trauma algorithms. So if you think about it, like kind of the coin of the realm, so to speak, when it comes to trauma is ATLS, Advanced Trauma Life Support, and it's fantastic. It works great. That's what we use. The language that we use, like the A, B, C, D, E. Actually, C is kind of coming up in front of A because we're identifying massive hemorrhage. Again, that's a systematic trauma algorithm that's been used for a long time. A lot of times in the wilderness medicine realm, and this actually comes from military medicine, is the March algorithm. And I think that probably for my purposes outside of the hospital, I tend to lean toward this personally. For me, I think it encompasses things a little easier from my standpoint, where of course, up at the top is massive bleeding. Again, if you've got somebody that's got an uncontrolled and sanguinating bleed, that's a terminal process. It has to be interrupted. So no matter what you do, you've got to stop the bleeding first. And then, of course, airway. You got a 100% mortality rate for someone without an airway. That's definitely up near the top of your priorities. Then respirations. I think, looking at this algorithm, I think at that point in time, that's more like supportive respirations, like rescue breathing. Maybe if someone's got a tension pneumothorax, maybe you're going to do a pleural do a decompression for them. Moving down to circulation. This this is again maybe not so much the bleeding, because you've already kind of sorted that out with the massive bleeding kind of stop that you've done. It's more like assessing that person's overall kind of perfusion state. With could be you could be looking at heart rate. You could be looking at blood pressure if you got a blood pressure cuff. Looking at capillary refill, that kind of stuff. There's cerebral perfusion, how they're mentating, and that kind of leads you to head. Looking for any significant major head injuries, and also making sure that you've got a good baseline kind of like mental status for these folks. Again, you're not going to be having them like count backwards in serial sevens, or draw you a clock, or do dysthiokinesis and that kind of stuff. It's going to be much more focused, kind of neuro kind of assessment, and it's good to have that for a couple reasons. One, now you have a baseline. If that starts to change, you know that you may need to change your treatment strategies as well. And then again, of course, hypothermia is there, and sometimes people actually add in like helicopter and hike to kind of bring in the evacuation kind of process there as well. And I'll talk a little bit more about hypothermia later, but it's one of those things that I think is critically important, particularly in river medicine. And if someone is taking a long swim in water, they're automatically at high risk for hypothermia, particularly if they're a trauma patient. So again, we'll talk about that a little bit more in a few minutes. So again, trauma assessment: identify and address immediate threats to life. Always aggressively treat major hemorrhage, airway compromise, support breathing, CPR, stabilize, evacuate, and monitor. And so when it comes to CPR, there's discussion out there about its effectiveness. And again, that's might be a little bit outside of the scope of today's conversation, but I will say that for drowning patients, CPR can save their life, regardless of kind of where you fall on CPR for like other things. A drowning patient, if you can get good high quality CPR started on a drowning patient within 10 minutes of the incident, that can significantly improve their odds. So CPR for drowning patients. Also lightning strike patients. Again, a little off topic here, but again, CPR for those two sets of patients is can be life-saving. And then of course, stabilize, evacuate, and monitor. These are all things that we're going to be doing throughout our trauma assessment and treatment process. So I feel like we can't talk about trauma if we don't talk about tourniquets. I'll tell you guys, right now, tourniquets are so cheap, and you can buy them on Amazon. I am not endorsed by Amazon to say that. You can buy them from, I don't know, an internet retailer, and they're pretty inexpensive. So I think that having one in your trauma kit is great. I think it's a pretty essential component to a trauma kit, in my personal opinion. Improvised tourniquets, sure, they're great. They're just not going to be as effective in most circumstances. So again, just to talk really quickly about this, I know most people do have a pretty good idea about tourniquets and tourniquet use. The pendulum kind of has swung back and forth over the years. But again, what it comes down to is that no one should exsanguinate from a limb bleed if we have a tourniquet. The idea that if you put a tourniquet on somebody, they're automatically going to lose that extremity, the science just doesn't bear that out. So again, even in like in orthopedic surgery, when I worked in orthopedic surgery, I worked doing total joints. We would put tourniquets on patients for up to 2 hours for an elective procedure. So again, it's the idea that putting a tourniquet on someone is automatically going to cause them to lose their limbs. That's just not so. Again, with sufficient to stop blood flow, I talked about that a little bit before when it comes down to improvised versus across the shelf tourniquets. Place as distal as possible. Don't place it over a joint. The release and re-tourniquet method is kind of discouraged. I guess there for a while. It's like, and again, you'll have different opinions on this, but from my understanding is that if you put a tourniquet on, you really need to commit to it staying there. And then you need to tighten until the arterial bleeding stops. Not till it's slow, but till it stops. If you've got somebody who does have a significant extremity injury and they have salvageable tissue distal to the injury, and you put a venous tourniquet on, so maybe you've still got some arterial blood flow into that tissue with no venous return, it can set them up for some pretty deleterious sequelae. So I guess the thing is that if someone is suffering from a life-threatening bleed, use a tourniquet, but just make sure that you're committing to using it correctly. Oh, I got something here. Let's see here. Caution with some tourniquets you buy online from some retailers. There are many counterfeit products that have been shown to have high failure rates. Great point. Thank you. Is that Darwin? Thank you for bringing that up. Yes, absolutely. Make sure that you're buying it from a reputable medical supply company. Absolutely. Thank you. So musculoskeletal, let's talk about that a little bit, because again, you can't talk about trauma if you can't talk about bones. So femur fractures, again, stabilize. I feel like, and this is just my personal experience, and please feel free to chime in if you guys would like. It seems like the utilization or the teaching of improvised traction splints seems to have fallen out of favor to an extent. And I think from what I've understood is that it's one of those things, if you don't practice it and you're not really good at doing it, you could actually, they could actually cause deleterious sequelae, or could cause more damage. So again, a lot of times just trying to get them as stabilized as you can. And different people have different ideas about that. But if you've got, again, a manufactured traction splint, depending on your resources, great. But it seems to me that there's been less of an emphasis on talking about doing improvised thermal traction splints. Give me just a second, guys. I'm going to see a couple of chats here. Traction splints seem to have such a niche indication too. Yeah, exactly. So it's one of those things where you just got to be, it's got to be the right injury at the right time in the right place. So you just don't see folks using them quite as much or emphasizing their use as much. Thank you, Gina, for bringing that up. And here, I was wondering about how water temperature affects CPR for drowning victims. I heard colder water immersion may merit much longer CPR time. No, that's all right. So Allison, I'm actually going to talk about that in even more depth here in a few slides. Okay, so we're going to talk a little bit in the drowning section of the talk. We're going to talk a little bit about how water affects treatment, or water temperature affects treatment. Does that answer your question, Allison? All right, cool, good. So pelvic fractures, again, you can lose a lot of blood in your pelvis, up to 3 liters. Pelvic binders, again, they manufacture pelvic binders as well. I've trained with them. I've learned how to use them. I've actually never used a manufactured pelvic binder. Every time I've ever done it, it's been with a sheet. And again, like I said, we're just discussing it. It's not about teaching you how to do a pelvic binder. It's just like saying this is something that if you want to learn how to make an improvised pelvic binder, I definitely recommend taking a formal course for this. But again, just understanding that this is something that can be potentially life-saving in the field, tamponade that's leading in those unstable pelvis fractures. So musculoskeletal continued dislocations. So there's nothing cooler than being able to fix a dislocation in the field. Okay, now sometimes that's possible, sometimes that's not. So really, if you think about it, in the ED, the treatment, or just the treatment in general for a dislocation, is reduction. Of course, if we're in the hospital, we have things like sweet morphine and all kinds of pain medicine. We've got, milk of amnesia, otherwise known as propofol. We've got imaging, we've got support, we've got all this other stuff. So there's really no question on what to do with the dislocation when they come into the ED when you got these resources, or to the hospital when you have these resources. But if you don't have those and you're in the field, that changes things a little bit. Now, depending on your skill set and depending on your training, and someone does have some neurovascular compromise, maybe from a dislocated shoulder, it might be a conversation to have with a patient. And again, it's another thing too that people, I think, it's important to realize too, that we, just because we're outside of the hospital doesn't mean that we don't have to get patient consent for things. So there may be a situation where if you're out kayaking with your buddy and dislocate their shoulder, and you're like, hey, do you want me to try to reduce that? They may be like, no, man, put me in a sling and take me to the hospital, and they can reduce it there. And so there you go. The decision's made. Now, it might be a little trickier if someone does have a neurovascular compromise or injury there. The conversation might go a little bit differently. But the reality is that there are a number of techniques that can be performed in the field for different types of joint dislocations. And again, as I said before, if you really want to get down in the weeds on that, I recommend taking one of those formal courses for it. But again, in some circumstances, if someone does have neurovascular compromise, or they're not going to be able to self-evacuate with that dislocation, it might be a conversation. It might be something that may need to be attempted in the field. So fractures, provisional reduction with general traction works pretty well. So again, we have to set our expectations a little bit differently. Like if I had a patient that comes into the ED and they've got a significantly displaced distal radius fracture, yeah, we're going to procedurally sedate them. We're going to give them hematoma block. We're going to reduce them. I think it might be, and again, there may be some folks that would argue with me on this. I think that having the expectation you're going to be able to get that kind of reduction without those things out in the field, I think is I don't know how realistic that is. So I think that probably for me, I look more to like a provisional reduction and evacuation in those circumstances. So again, I think setting your expectations about how well you're actually going to be able to reduce a fracture in the field, I think is important. So again, really, when it comes down to it, it's if it's crooked, you try to straighten and immobilize it. And I will tell you that when you are going to apply some sort of musculoskeletal immobilization splint, you've got to make sure it's really well padded. Because again, even in the hospital, having a good well padded splint is critically important. I think it's even more important if you're outside of the hospital and you may be doing some evacuation and maybe moving things around the patient. We got to make sure that we're not going to cause more injury to that extremity with our splint. So it's really hard to overpad these things, if it makes sense. Also, if someone has a significantly angulated fracture, often it's worth at least trying to gently straighten that, just with some longitudinal traction. It'll help to protect the neurovascular structures, and it's also much easier to splint. But again, if it's significantly deformed and you're trying to reduce it and it's just not going, sometimes you may have to splint it in place. If somebody has an open fracture, that's what I like to call a peek and shriek injury. It's like you see it, you don't want to look at it anymore, you want to cover it up. Clean off, do some general cleaning of the bone if there's exposed bone there. Don't scrape it, don't pick at it, don't go rooting around in there, don't try to explore necessarily. Try to clean it off the best you can. If you've got some sterile gauze, something wet, as clean as you can get, cover that up, and then splint them as normal. I don't know, and again, different people have different opinions. I don't know how much benefits you're going to gain by trying to reduce and try to push that bone back into the soft tissue, depending on the fracture and again, your skill level. But I think that in many circumstances, just being able to cover that up, get it mobilized, and make sure that you're evacuating them to definitive care. Also, if you've got some antibiotics on your trip, this might be a time to go ahead and start those. I also have a thing here, cravats. They're a really high-tech piece of equipment, being a little facetious there, of course. They're pretty much triangular pieces of cloth that you can buy pretty cheap, or you can make them. They're indispensable in all sorts of ways, with like making slings and stuff like that. So also, another thing to make sure that we remember is that anytime you put a splint on somebody, you got to make sure you check their neurovascular status after you place the splint, just like you would in the hospital. So that kind of moves from our trauma chunk here. Looks like we're going pretty well. Not moving too, am I talking too fast? Everybody keeping up okay? Just let me know if you need me to slow down. Sometimes I'll kind of hit a high gear and just kind of roll with things. So just pull me back in if you need to, all right? So let's talk about drowning. Important stuff here. So there's been a lot of different terms used to describe drowning. It's a process. What it really comes down to, the best probably description of this is it's a process of pulmonary impairment, usually in a liquid environment. So it's a process. And I think that's what's critical. And if you think about it as a process and as a continuum, I think you get a lot more kind of like prognostic and clinical value out of it. There's older terms like near drowning, submersion injury, secondary drowning, and then sweet goodness, dry drowning. So that's something that came out a couple years ago. It kind of emerged and then kind of seems to have kind of passed a little bit, so we don't see it as much. But it was I think associated with like a drowning kind of incident or a submergent incident, and then a delayed kind of a significant pulmonary event later. There's no it doesn't fit. There's no medical or clinical value in the term dry drowning. So again, you'll hear people talk about it. I just want to reiterate, this is not a thing. Okay, so all right, I'll get off my soapbox now. So it's a continuum that has to be interrupted. So again, there's different ways that this can happen. So if someone comes out of their boat and say they get ejected, say they go through they just get completely clobbered in a rapid, and for whatever reason they swim out of their kayak. Maybe they bonk their head, maybe they don't. But you come up to them and they're floating face down in the water. Okay, right now this person is drowning. Okay, because their face is in the water. Ooh, hang on. So curious about the struggle with clearing C-spines in the field, thoughts on using clinical decision rules in that field that have not been validated in the capacity. Yeah, so that's a tricky one. So again, you'll run into different people that have different thoughts on that. I think there's a value in using some of those, and I've seen a couple. I think right now, I think right now it probably bears a little bit more validation before I would choose one in particular. Does that answer your question, Audrey Marcotte? Okay. Oops, sorry. Let me get back if I can. All right, good. So let's talk about getting back to our drowning patient. So we take this patient with their face in the water and we pull them out of the water. So now their face holes are now able to exchange gas instead of fluid. So if we pull them out and they're kind of coughing and spluttering, we interrupted that drowning process? We've interrupted it. But if we pull this person out and they're coughing and spluttering and are acting air hungry and they're having a hard time breathing and they're not really respiring, technically they're still drowning, guys. I mean, we're still on that continuum. Does that make sense? So just getting them out of the water sometimes isn't enough. So again, thinking about it, and so getting back to that patient, that person, we're gonna have to make sure that we are supporting them from a respiratory standpoint the best that we can and trying to get them evacuated as quickly as we can. Oh, while on the drowning topic, thoughts on CPAP for needle drowning? That's a great question, Kenny. And I'm not sure. That's an excellent question. It's not something that that I've had much experience with. So I'm sorry I can't give you a great answer on that. But I'm happy to kind of dig into that. And if you want to send me like an email or way to contact you, I'm happy to follow up with you on that if you want. Okay, gotcha. We're going to Jersey Shore lifeguards and stuff. Okay, got it. And again, that would be something that, I could see the benefit there. I just want to make sure if we're going to have the conversation, I've got like all the information, be able to have that, a really well-informed conversation about it. And right now, when it comes to CPAP and near drowning, it's not something that I'm as versed in. Okay. Getting back to drowning has 3 outcomes, just 3, 1, 2, 3, either fatal drowning where the person succumbs to their drowning injury, non-fatal drowning with injury sequela, usually central nervous system or neurologic sequela, and then 3, non-fatal drowning without injury sequela. So this is kind of the way that, when you look at drowning, I think it's probably the best way for us to be able to use that information clinically and deliver the best care that we can for our patients. So let's talk about risk factors. Risk factors for drowning. Yeah, sorry fellas, gender and all age. Alcohol is another big one, and we'll talk about that in a few minutes too, about personal choices. And then associated trauma, of course, is going to be a risk factor for drowning as well. If someone is sustained major trauma, it's going to be much harder for them to be able to self-rescue. And of course, this joke never gets old. It's like, when you start talking about risk factors for this kind of thing, it's Y chromosome poisoning with our male population. So let's talk a little bit about personal choices and protective equipment. So one of these things is not like the others. You will see all 3 of these things on the river, okay? There seems to be more frequently, I'm seeing more PFDs out there, and I'm starting to see a little more helmets as well. You have different people have different philosophies and different ideas about like what type of protective equipment that they should use. Guys, I'm just going to go ahead and just I cannot more strongly recommend that you wear a life jacket. I have never met anybody that says, wow, I sure wish I didn't have this life jacket on if they're swimming through a rapid. So again, there's a lot of benefits for them. If you're out there in the cold, they help keep you warm. The biggest thing they do is they help keep you afloat. They can keep you warm, and also a lot, especially like the nice whitewater PFDs, like they'll actually offer you some protection to a certain extent, a little bit of cushioning there. When it comes to a PFD, you're much more likely to wear it if it fits correctly. So you want to make sure that the PFD that you get does fit correctly. You know how to use all the features that are on it. And the most important thing is just wear the darn thing. Just wear your PFD. I can't recommend that more highly. Some people will say, well, if it's just flat water, I need to. It's like, well, maybe not. I mean, again, it's all about personal choices. But again, getting back to what I mentioned before about that community, you'll hear people in the river community talk about this, is that the decisions you make, your choice to not wear a helmet or your choice to not wear a PFD can directly affect what I need to do if you get into trouble, even if I don't know you, if I'm on your trip. So think about it in those terms as well. Again, if you're on moving water of any fashion, I cannot more highly recommend wearing a PFD or a life jacket. Now, helmets, Some people do that splits out just a little bit more. Some folks are like, well, should I have to wear a helmet on like class 3 rapids or above? Do I have to wear them in class 2? Do I have to wear them on Tuesdays? Again, there is, again, maybe a little, you can tease that apart just maybe a little bit more depending on the type of boating you're doing, but still, again, it's never a bad idea to be wearing one. They're not going to hurt you. And particularly if you're in a kayak, if you're in a decked boat where you actually have a skirt on, you should always be wearing a helmet when you're in moving waters, simply because if that thing flips over, you're kind of in the boat. If you whack your head, you're going to be unable to self-rescue if you get knocked unconscious. So again, definitely wear that PFD, and I very strongly recommend if you're in any kind of moving water, any kind of rapid, just put a helmet on. We've invested a lot